I'm Dr. Kumar, doctor from Mumbai. So every year we decide what more tough cases we are going to do. So every year we have a new resolution coming up. So you want to enjoy life, get fit, get a better job, take a trip, lose weight. So everyone has their own resolution every year. So I decide as we get more and more experience, we do face tougher situations. And then what are the other options? Now this was a very interesting case. You can see that he's fishing an IOL. So this patient was operated by me about 25 years back. Details of the old surgery are not there, so I do not know which IOL is there. B scan was done, and on the indirect we can make out that there is an IOL, but you can't see the design of the IOL. Specular, no history of trauma, plan the action, and what are our options? One option is to explant the IOL which is already there, re-implant another glued IOL, or do a posterior iris fixation. And you'll see what I did is very interesting. And you may have never seen anything like this before. So you can see that the IOL is missing and you can't see the back complex. So this is known in some scenarios where the whole thing is missing. And once in a while, if you move the eye, obviously there's a block, you can see something moving, but you can't make out what it is. So of course go ahead and put your trocar. Once you've done your trocar, you have to plan, right? So you have to plan as to how are you going to go about this. So I decided that let us measure. First thing is to get your white to white. And I thought that I will do a glued IOL. And thanks to Amar, who is with me here, who is the inventor of many things. Like how we make a list of awards we win, he makes a list of inventions he does every month. So this is making the flaps for the glued IOL, which is very crucial and important step. And I made one side pot, okay, and then I'm making another side pot. And then of course there is vitreous in the AC, we do staining. And to my luck, the 3-piece foldable IOL, not foldable, the 3-piece IOL comes up. And I immediately grasp it with the micro grasping forceps, okay. Now, some of you may not have even seen this kind of an IOL. As you can see, this is a 6.5 millimeter optic with dialing holes. In olden times, the optic used to be larger and there used to be dialing holes in that. And you can see it's a J haptic. It's not modified J, it's not C, it's not modified C, but they are large haptics and they are J. And you can see that I've got the IOL completely in the anterior chamber. But if you notice, the angulation of the haptic is not correct. It is in the opposite direction. So this is one haptic and this is the other haptic. These are the dialing holes which used to be made originally, and that helps you to put the IOL in the bag. That's why they were invented. So now I am flipping this IOL in the AC itself. Now why have I done that is so that the J comes in the right orientation for me to glue. Another thing is these IOLs are non-foldable, so you can't cut them. And another thing, they had a 10-degree angulation, so I could not have left it upside down. Once I have done the flip, I just go ahead and then do the glue technique with a handshake technique. But in these cases, you have to be very careful because these IOLs and haptics are extremely brittle. They are not as malleable as the new generation IOLs. You saw that a large haptic portion comes out. And then go ahead. So here what is the take home message is that the same IOL, so no need for calculation, refitted through 2 side pots with an MVR, and we glued the same IOL back, and the patient did extremely well because it's his own IOL. At the end of it, just put the glue and go ahead. So refitting is better than explanting, no need for a larger incision. Older design, as I mentioned, newer design IOLs are much easier to hold, and this will make the IOL stable forever. Now this is another case where you will see a patient with a large, same large optic with a 6.5 millimeter and subluxated. Again put in a trocar, make the glue. And this case we decided you can't use a Malugan ring. Remember this, if you have a small pupil, don't put a Malugan ring or a B-hex ring. You have to use hooks because that only will give you enough exposure. So once you use the hooks, you can then remove all the vitreous that is holding on to the IOL and bring the IOL up in the same direction as that is necessary. And once this is done, you can see that once go ahead and then put it. Now this you can see that the same lens which was subluxated is now brought up, and make sure that all the traction of the vitreous all around, in front and behind and around the IOL is removed. So use the same port to do the vitrectomy and remove it, make it free, and this haptic can be held gently. Always hold the tip. So again, this is a handshake technique. Hold the haptic, go through the underneath the flap. Once you've done that, remove that hook because that's not necessary. Hold the haptic, go in through underneath the flap, and always make sure that you hold the tip of the haptic, and that will really help you to bring the haptic out. And once that is out, you can just glue it. So same story, again a subluxated IOL refitted. Now this is another case, again a subluxated IOL, but you can see a posterior capsule and an anterior capsule fused. Now this pupil does not dilate, nothing happens. So again, same story, if it does not dilate, you can't use a ring, you have to use hooks because that gives you adequate exposure. Once you got your adequate exposure, now the question is, it's a 3-piece IOL. These are the new generation IOLs, and I want to not remove it because I can refit it. So what I'm doing is centering the IOL, making sure I mark the center on the visual axis, and then I go ahead. Now you have a fused anterior posterior capsule. You can see the fused anterior posterior capsule here. Once that is done, I now just do a little bit of vitrectomy there and make sure that I make a little opening. Now how do I make sure that this same IOL which had subluxated does not again subluxate or dislocate? So I'm doing an optic capture in the fused capsular complex that is present. So I'm just now nudging the inferior part of the optic inside, and then I'm nudging the superior optic inside and making sure that it goes ahead and just stays. So this way, the optic capture has happened in that opening that I made in the back complex, and this will always remain well centered forever. Just one more case I will show. Again, this case was operated by me many years back. It's a twin set bifocal IOL. Some of you might not have seen this IOL. And this patient, you can see the rings down, you can see a nice pupil. Patient is allergic to Topicacil Plus. When you dilate and see, this is all that the pupil really dilates. And you can see one nice round opening in the center, and that's a YAG opening. Now this is a multifocal IOL which is subluxated, and obviously the patient wants multifocality. So what are our options here? Let me show you that. So this is a YAG opening. You can see a beautiful, nice round YAG opening. So again, under topical anesthesia, you can see a subluxated or a dislocated IOL, okay? And this is a bifocal IOL. I put intracameral epitrate and the pupil beautifully dilates, and you can suddenly see the two haptics. This is known to happen in this IOL. I've had 3 cases like this. For those who have used this IOL, they know about it. So one haptic that you can see here is in the fused back complex. One haptic is anterior and the optic is lying free. Go ahead and put triamcinolone on, make sure that you do the vitrectomy, and then coming to the explantation of the optic, you have to make sure that whenever you want to explant any optic, use the incision as a fulcrum, micrograsping forceps, cut the optic. You don't need to cut through and through till the other side, just cut half of it, so 3 millimeter, and then I'm just going to hold the optic and use the incision as a fulcrum, so that you can just remove it. Once you just hold the incision, hold the optic, just rotate it around the incision and remove it. Once that is done, as I mentioned, one of the haptic is floating free in the sulcus. That can easily be removed. The other haptic is sitting nicely between the anterior posterior capsule. Don't bother, just let it be there. It's not going to come in your way. Don't forget, this patient wanted multifocality. Now what to do? So that's the next question. Go ahead, do your vitrectomy. Then use a 3-piece multifocal IOL. No financial interest, this is available, and put this IOL in the sulcus. And again, the question is, this 3-piece multifocal IOL should never dislocate or subluxate. Again, do an optic capture in the YAG opening that was there, and this will always maintain the centration of this multifocal IOL, and the patient will be quite happy for a long time to go. So these are some of the cases that I have shared. I have a fantastic panel with me, Chitra, Amar, Gaurav and Rohit. I invite Dr. Chitra, you ready? Dr. Chitra to give her presentation. So this is all about subluxated IOLs and back complexes. Thank you very much.